preceding talkers have been talking about how to open things. I'm going to talk about how to close things, which is sometimes something that we have to do. And to illustrate that, I'm going to start with an interesting case we did originally a couple of years ago, actually, of a gentleman that's 76 years old. He had 4-vessel CABG a while back. He did okay for a long period of time, and then he started developing some symptoms again. At some point, he had PCI of his SVG to the occluded RCA. He has dyspnea and exertion, fatigue, and dizziness. He has a positive stress test with inferior wall ischemia. And his referring doctor orders a CTA. And as you can see on this CTA, the problem is, if I get the pointer to work, that there is an aneurysm in the mid-portion of the SVG to the RCA that's partially thrombosed, and it's compressing the SVG. So the thinking is that this is creating ischemia. You can also see that his RCA, his native RCA, is completely occluded. So the question is, what do we do with this? The thinking was that we're going to take him to the lab and open up his native RCA, and then at the end of that, close this SVG so we eliminate this aneurysm. So we brought him to the cath lab. These are dual injections. You can see here the flow through the SVG, retrofilling the RCA. This is the portion where the aneurysm is. You see a little pulsatility here. I'm not going to go over the details of the CTO PCI. We ended up going retrograde, did reverse cart, and got a good result. And at the end, we decided to close this. And we do this sometimes for this SVGs following opening of the native vessel. In this case, we elected to go with coils, and we placed 4 6mm Axium coils right at the area of stenosis here. And at the end, as you can see, we have nice flow through the native RCA, which is important. And we have very limited flow, but still some flow through the SVG. So in a situation like this, one hopes that this slowly thromboses in time and everybody's happy, right? So just because of the aneurysm, we elected to bring this guy back, and it didn't look quite like what we expected. So several problems. Not only that there is flow through this SVG, it looks like there is flow through and through this SVG. The aneurysm is still there, and it actually has flow in it now. And not only it has flow, it has a fistula to the right atrium. So things have gotten a little more complicated now than what we were hoping for. So the question is, what do we do with this now, right? So the other question here is whether his RCA, native RCA, is patent or not. It kind of looks patent here, but it's hard to tell because you have so many stents in there. So we talked to the CT surgeons, and the thinking was take him to the lab, define this anatomy really well, and if it's indeed communicating from both ends, this aneurysm, the only solution that we have is probably a surgical intervention, because if you close one limb of this, there will still be flow from the other limb into this aneurysm. So we took him to the lab, and of course the RCA PCI result looks great. And the lucky thing was that this vein graft is actually not continuous. So the distal part of this vein graft past the coils that we placed, it's actually occluded. But it does fill antegrade, and as you can see here, these coils are floating inside this aneurysm now, and there's clear communication to the right atrium. Interestingly enough, when you engage this, the pressure drops instantly to basically systemic venous pressure. So the question now was, well, do we have a better solution than sending this guy to surgery? So now this thing potentially fills from the proximal limb, from the right atrium, but it does not fill from the retro limb, and we have a patent RCA. So it's kind of the best case scenario here. So we elected to try again to close this in a more definitive fashion, and this time we used a vascular plug because coils didn't do it that well first time. So this is an AVP4 that's placed in the proximal segment of the vein graft. Luckily, there's actually a stent there that makes things so much easier. 5 minutes later, we inject some dye, and we finally managed to close this thing. Perfect. And just to be 100% sure, we brought him back a few months later for a repeat CTA, and again, you can see here the AVP in place. The graft is definitely closed, and importantly, there's no flow in this aneurysm, so presumably it's thrombosed now. Echo looks okay, so we finally achieved victory. So when do we close these things? In this scenario, when you have an aneurysm of the vein graft, that's probably a good indication. I've seen some disasters with patients who actually rupture this aneurysm. or when there's significant competitive flow after you fix the native vessel. This is an example of that. This is a gentleman that had a prox LAD, CTO with a degenerated vein graft to this LAD. We fixed the native, but as you can see here in the middle panel, there is strong competitive flow still from this vein graft. If you leave it like this, there's a good chance the stents are going to thrombose. So we elected to coil this thing, and we got a nice result with good flow in the native. Again, this doesn't happen immediately. These coils almost never, in my experience, have closed these vessels instantly. There's always some flow. The coils that you use depend on what you're familiar with, what you have in your lab. Medtronic and Boston Scientific make these coils. You need a slightly larger microcatheter to deliver. The vascular plug, the AVP, is a product that can be used here as well. This is the 4th generation vascular plug. It's sized, the size is suitable for vein grafts. You have to oversize it a little bit. It's easy to deploy. If you need questions, if you need to figure out how to deploy this, just ask the guy who does PFOs in your lab, because he'll tell you exactly how to use this thing. And this is my 2 cents on when to use one versus the other. Of course, there's no data in the cardiac literature, but there's some data in the interventional radiology literature. They are equally expensive, so a coil is almost as much as an AVP. So if you use 4 coils, that gets a little more expensive. And probably the more flow you have, the more likely it's a better idea to use a vascular plug rather than coils. And I just want to finish with this. This is from the CTO Fundamentals community website. A couple of years ago, this question came up, and people have suggested that perhaps we should collect data about SVG coiling and see if we should do this routinely following native CTO PCI or not. And I think the consensus is this, that if you have a very good flow to this vein graft after you fix the native, perhaps coiling the vein is the way to go. But if the flow is poor, the vein graft will close on its own. So thank you for your attention.
Thank you so much. So anybody have any questions or comment?
Question I asked a few days ago. So, I always struggle with this. In this case, that second case, the LAD or that vein graft almost had like a Lima type flow. It's very brisk, but when it's not brisk and you fix a CTO and the majority of the flow is going through your coronary, do you still have to do it? I just don't know when to do it. I feel uncomfortable shutting down a graft that's almost on its way out anyway.
No, I agree. I mean, that's exactly the point. If you inject your native and you have good flow past anastomosis, I think you're good. But if you inject the native and there's no flow past anastomosis, then probably you should think about it, because the stents are going to thrombose and,
I actually have a stent thrombose because I did not close the SVG. The first time I did it, I was new at Henry Ford Hospital, and they sent me to the principal's house, office, because they can peer review committee and all 9 yards, so I did not do it for a long time until I had another patient who had a lot of competition and basically stent thrombose. But the choice of coil is really important here. And so what's your preference? Is it that vascular plug device or the coils?
Well, after this experience, I would go with an AVP, to be honest with you. If you have a landing zone to place it, because it's much more material that you place on the graft, so that leads to a much more effective, closure of the coils. You never get, you put 4 or 5 coils, and at some point you start thinking, well, let's go to bed.
And in the coil, you have to put an anchor coil at the beginning. You put the biggest coil you have. That will be the anchor coil, and then you tack coils above it. And the coils, the other drawback to them, they are very radiopaque. So if you put them above your cardiac silhouette, you're not going to be able to see your heart later. So the vascular plug is actually a lot less radiopaque and a lot more effective. Thank you so much, Catalin. All right.